Hello, boleh dengar kan? Okay. Good morning, doctors. Today, my CME topic is DVT. My supervisor, Dr. Rohayu, especially thank to Dr. Fairuz for my technical problem. So, this presentation slide consists of 3 parts. First, definition and etiology. So, DVT is a formation of blood clot in one of the deep vein in our body. Most common occur in deep vein of the legs, either above the knee or below it. So DVT of lower extremity usually begin in the calf and propagates proximately to the popliteal vein, femoral vein, and iliac vein. The lower limb DVT is about 10 times more common than the upper extremity DVT, which is often precipitated by placement of pacemaker, internal cardiac defibrillator, or in Wielding center venous catheter. So, okay. So the virtual track has helped us to identify the 3 main factors of why blood clot develop within the deep veins, which are hypercoagulability, venous stasis, and endothelial injury. So by looking at this risk factor identified by virtual track, we can take preventive method in this patient to prevent them from developing DVT. So for venous stasis, patient age more than 40, immobility, patient might be prolonged bed rest for more than 4 days, extended travel in a vehicle, stroke patient, paralysis, spinal cord injury patient, hyperviscosity, polycythemia, severe COPD, anesthesia, and varicose veins. These are examples for venous stasis. Next, hypercoagulability, malignancy, high estrogen status patient, surgery and trauma patient, patient having acquired disorder of coagulation like nephrotic syndrome and antiphospholipid antibodies, patient who has inherited disorder of coagulation, for example, thrombophilia, sepsis, smoking, pregnancy and postpartum, obesity, these are categorized under hypercoagulability. Next, endothelial damage causing by trauma, surgery, prior VTE, invasive procedure like central venous catheter insertion over subclavicle internal jugular lines. This line might cause the upper extremity DVT. So next, the part 2 is the sign and symptom and also diagnosis. So usually patient will presented complaint of pain in the leg, tendon in the calf, swelling usually only in a one limb, redness, warm, skin discoloration, might be on the affected area turning pale or reddish bluish color, and cyanosis when a severe obstruction happen. So these are sign and symptom. Next, clinical examination, human signs, Bancroft sign, Phlegmasia alba dolens, and Phlegmasia cerulea dolens. So these are some tests we can do on the patient. Human sign, a test for DVT over the calf. So patient lying supine position, the examiner squeeze the calf firmly and dorsiflex the foot like in the picture. So this test is considered positive if the deep-seated pain is felt by patient in the calf.
If you think this is confirm a DVT case, this is a very cautious procedure because it can precipitate the further dislodge of the thrombus.
Another one is a Bancroft sign. So it's a clinical sign found in patient with DVT over lower leg involving the posterior tibial vein. So the sign positive is the pain is elicited when the calf muscle is compressed forward against the tibia, but not when the calf muscle is compressed from side to side. So like what Dr. Villa have mentioned, it's not advised to do to prevent the clot from falling and dislodge and cause a further PE. So, Phlegmasia described 2 clinical conditions due to extensive DVT, Phlegmasia alba dolens and Phlegmasia cerulea dolens. So, Phlegmasia alba dolens is also known as white or milk leg. It presents as a threat of edema, pain, and white blanching skin without cyanosis. And then, as the venous thrombosis progresses, it might develop into a Phlegmasia cerulea dolens, which I've shown in the picture. This is Phlegmasia dolens. So it usually presented with blue leg. It's an uncommon, very severe form of iliocover and iliofemoral DVT. It causing total outflow obstruction with rapid extension of thrombus into all deep and superficial vein, causing a sudden severe ischemic pain, massive congestion of the limb, cyanosis, function loss, tachycardia, and shock. It may be complicated by massive PE, compartment syndrome, and also potentially lead to venous gangrene. So cancer patient and hypergoluble states may play a major role in development of this rare condition. Phlegmasia dolens is an emergency, so treatment must not be delayed. The amputation rate may up to 50% and mortality rate may up to 40% for patients treated with only anticoagulation alone. So the initial management is with adjusted heparin initiated as promptly as possible and delivered in combination with aggressive leg elevation and fluid resuscitation. So it's also suggestive that surgical intervention should be proceed as fast as possible lah. For example, CDT, PCDT, fascectomy, iliac stenting to reduce
CDT, PCDT tu apa? Sorry.
Their
The full term lah.
full term
I assume T tu thrombectomy lah.
but I need to find out the full name. So surgical intervention can reduce the amputation and mortality rates there. Next one is a diagnosis. So Wells score is for a prediction of lower extremity DVT, which we are usually using in our clinical practice. So they consist of 10 criteria. First is the active cancer, paralysis, or recent cast immobilization of lower extremity, recent bedridden for more than 3 days, and has major surgery within the previous 12 weeks, requiring general or regional anesthesia, localized tenderness along the distribution of deep vein system, entire leg swelling, calf swelling at least 3 cm larger than on the symptomatic side, and pitting edema confined to the symptomatic leg, unilateral collateral superficial vein, previously documented DVT, alternative diagnosis at least as likely as the DVT thrombosis. So from this scoring, it categorized patient into the original score categorized patient into 3 risk group, which is less than 10 score is a low risk group, 1 to 2 is moderate, and more than 3 is high. But the modified one categorized patient to unlikely and only likely patient. So this is according to the Wells score, but it's slightly different from what we practice because they have highly sensitivity D-dimer and also moderate sensitivity D-dimer, which we don't have. So according to Wells score, so I can, I'm not very sure about that.
Kan dia ada kalau based on the response you classify into two kan.
Betul.
A score of 0 or lower ataupun score 1 to 2 kan. So actually kalau dia ada comel lah. Saya cakap pun masuk comel tu. Okay, based on the diagnosis, so mainly dia based on the West score kan. So West score you boleh classify into two. Kan, either you go to the next page. Dia kata a score of 0 or lower is associated with DVT ataupun a score of 1 to 2. Okay.
Ada lagi yang score 3
tapi
and above.
if kalau score 0 or lower, dia just D-dimer tu moderate sensitivity. Betul? Kalau a score of 1 to 2, you required high sensitivity D-dimer. The question is, our lab, we are using which type of D-dimer? Kan? Sebab dia kata kalau kata score 0 or lower, D-dimer you dapat negatif, memang you boleh rule out terus. Right? Dia moderate D-dimer lah. But for the score 1 to 2, you required high sensitivity. D-dimer untuk you rule out this is not a DVT. Kan? So we must know kita punya ni lah type of D-dimer. Anyone can answer? Ada siapa kat sana? Tak apalah, Ipan lah nak tanya lah. So I just confirm kita punya lab. They mention that our D-dimer is high sensitivity and high NPV. NPV ni negative predictive value. So kita punya high sensitivity lah. Okay? Another question is ultrasound. Dia boleh ultrasound. Dia kata a negative, high or moderate sensitivity D-dimer result probability less than 1% and no further imaging is required. But when you get a positive D-dimer, okay, you should proceed with ultrasound testing. Cuma ultrasound ni, what type of ultrasound? Only compression test ke ataupun you kena track?
The track one.
Maybe Dr. Tati boleh bagi input.
Kalau kita ADPD, kalau share kita buat 2-point compression je. Tapi kalau still you need to confirmatory from the radiology to track all the venous system of the lower limb. Kalau point of care, memang 2.2 zone compression. Bukan 2.2 zone.
So kalau positif ultrasound positif ultrasound
Dia dah zone.
positif tak apa dah problem.
Satu zone tu
Cuma kalau score high, okay, score high,
Kalau you buat finger je, dekat dia ada 3 area.
Orang online tak dengar.
tak apa, boleh continue dulu. Can continue dulu. Cuma our D-dimer is high sensitivity nah. Okay.
So patient presented with likely DVT, we can categorize patient under well score first, and then according to the well score, we'll to see if we need to proceed with D-dimer testing or not. So kalau well score 1 to 2 considered as moderate risk, so we should proceed with highly sensitivity D-dimer testing, which our hospital is carrying out now. So kalau D-dimer negative, so it's sufficient to rule out the DVT. If positive D-dimer, then we have to proceed with ultrasound to rule out the DVT. Negative ultrasound can rule out DVT. Positive ultrasound with DVT high score, DVT score 1 to 2. So strongly concern of DVT lah, we can start the treatment with anticoagulation. Next one, if the score is 3 or higher, suggestive of DVT, patients should receive a diagnostic ultrasound. So D-dimer carry out if a negative, if negative D-dimer, ultrasound have to be carried out also. So kalau ultrasound negative, can consider discharge. Positive ultrasound with negative D-dimer, strongly consider as DVT also. So well scored kalau high, DVT likely patient, and ultrasound positive, we still continue with treatment. If DVT likely but D-dimer positive but ultrasound negative, we have to repeat the ultrasound within 1 week. Okay, so this is only well score is only a clinical aid to make decision, but not a cost management lah. We have to apply a detailed history and also some physical examination before we perform the DVT, the well score DVT. And if patient there is no risk of DVT, then we don't have to proceed with the well score. So for all suspicion DVT patient, ultrasound should be carried out lah. So next one is the D-dimer. So D-dimer raised in the presence of DVT and PE because the breakdown of fibrin by plasmin. However, the D-dimer is not specific. It may result as false positive for patient under sepsis, infection, myocardial infarction, cancer, pregnancy, even old age. It will raise the D-dimer. False negative, there will be false negative also, particularly in patients that treated with anticoagulants or with a cuff DVT or the symptom already lasting for longer than 2 or 3 weeks. So D-dimer is just for us to just a value for us to decide to proceed with ultrasound or not. So next one is a venous ultrasound. This is what we usually do in ED. So a normal vein could collapse with a gentle manual pressure from the ultrasound transducer, create an illusion of wing, and two-point compression performed over the common femoral vein and popliteal vein. Patient lying in supine position with leg externally rotated and knee flexed. Using a linear prop in transverse orientation, apply a firm compression. The loss of vein compressibility is the primary characterization for DVT. So the diagnosis of acute DVT is even more secure when thrombus is directly visualized. It appears homogeneous and has low echogenicity. Next one is the CT venograph. Is a venography is an effective technique for diagnosed proximal DVT in patients with suspected DVT and PE. Its sensitivity and specificity comparable to ultrasound. It offers defined advantage over ultrasound when elevating the pelvic veins and inferior vena cava, and can detect concurrent medical conditions that cause pain and swelling. Moreover, owing it to excellent spatial resolution, it may facilitate vessel management and case planning when intervention is deemed necessary. But CTV is expensive and require use of iodine contrast and involve radiation exposed. So when come to younger patient, this test is more significant concern lah. Next is MRV. It's actually the benefit is like the CTV, but it can distinguish a matured from an immature clot, and also safer in all stage pregnancy. But it's also very expensive and involve IV contrast. So this one we are seldom considered. Venography is a first-line imaging for the diagnostic of DVT and considered gold standard. Although effective, but this procedure is invasive and require IV contrast, also involve exposure to radiation. So this is seldom performed now, except when other investigation is yield inconclusive result or concurrent catheter-based intervention is being considered. So out of all this diagnostic method, ultrasound is still the initial imaging method of choice in our practice.
So CTV, MRV, venography, sepanjang you jadi doktor ni, berapa kali pernah order?
Nampak CT je lah.
Masa kat medical tu dah pernah order tak? CTV, MRV untuk DVT.
Ya, ultrasound.
It's not cost benefit to risk versus benefit, cost factor pun is a big issue lah. So in the end, if high risk, you're gonna treat anyway, kan? So might as well just treat lah. Okay, especially if patient ada cost untuk ada macam bed bound ke, ke ada malignancy ke, might as well just treat lah for DVT tu. So jarang lah, I mean this all theoretical punya educational purposes lah. Kod lah satu hari nanti ada kerja somewhere yang modern sikit, semua orang order. Kat private maybe, kat private mungkin dia akan buat lah semua all the CTV or MRV lah, because it's the least invasive and they can charge more. They might just do everything lah, but your insurance is going to pay for it lah. Okay.
So this is a flow chart for the diagnosis and investigation of DVT. So first of all, always start with the history taken, and then some physical examination. So we can categorize patient into DVT likely or unlikely. If the patient is DVT unlikely, we can if the patient historical suspected and also clinically examination suspected, we can combine with our well score also, the well score also, and then we divide patient into DVT likely and unlikely lah. Kalau unlikely but we still suspected, we carry out with D-dimer. If positive D-dimer, we can carry out with ultrasound also. If the D-dimer measure is a positive D-dimer, we can carry out with ultrasound. So if ultrasound negative, DVT is excluded. If ultrasound is inconclusive, we can carry out with CTV or MRV. If positive, then we proceed with the treatment. Yeah. But maybe if the history
D-dimer also.
Orang lain tak dengar.
no, based on the diaphragm, they divide into DVT likely and DVT unlikely kan. So if already kata negatif, okay lah, you boleh exclude. And then kalau positif, under ultrasound, kalau you go to the flow, dia kata inconclusive or not feasible, you go to the CTV. Tapi kalau dah DVT unlikely, memang here pun also we don't practice CTV pasal semua MRV kan. So I think no need lah kan nak proceed dengan CTV MRV kan. Cuma in the flow yang belah the left side tu, the right side DVT likely tu memang maybe ada role lah. Tu pun maybe in ada hospital lah, don't know. Okay.
So,
Dekat ini ada flowchart lain tak? Misal kata, let's say kalau 2-point compression dah positif, and should we start the treatment earlier ataupun just wait for formal ultrasound before we start the treatment?
Okay, with regards to flowchart, memang tak ada lah. Tapi by definition, the moment you suspect DVT, especially bila dia dah moderate to high risk, maksudnya dia dah ada risk factors, moderate risk factor or high probability kan, you should initiate anticoagulation therapy lah. Meaning that should start Clexane or Clexane lah usually kita start untuk DVT. Sebab the other things that you do, D-dimer is just a matter of confirming your diagnosis. Especially bila D-dimer dah positif pun, unilateral leg swelling pun, then it's the rest of the MRV ke or ultrasound is just to confirm your diagnosis lah. Even if your ultrasound negative pun, patient to high risk, clinically possible, you just start the anticoagulation. Sebab in the end, the anticoagulation tu carries low risk lah, unless patient ada coagulopathy dan sebagainya. I mean, the risk of the anticoagulation therapy to cause bleeding is lower than, you know, the potential risk of patient nak develop PE or the DVT worsening. Okay, so if you suspect, you start anticoagulation because in the end you just start Clexane je, short acting, short half-life, kan. Bila patient masuk ward, I think if you're really concerned about starting Warfarin for the next 6 months, then you may pursue other investigation yang nak confirm lah. Because even if you confirm dekat ED pun, say you buat MRV ke apa kat ED pun, patient boleh discharge ke? Unless it's negative lah, boleh lah discharge kan. Tapi kalau confirm pun dengan ada DVT dengan MRV, you still gonna admit the patient because in the end, the reason for admission is because you want to overlap the anticoagulation Clexane, the Heparin dengan Warfarin kan. And you nak discharge patient with Warfarin when the INR is therapeutic. I'm not sure about all the dabigatran or whatever, you know, all this new oral anticoagulation in treatment of DVT tu I tak sure sangat whether dia ada actual protocol or not. That's probably something that kita semua kena baca lah.
So next one is differentiation diagnosis. So rupture Baker cyst, patient actually presented with acute sharp pain and swelling in cuff. So ultrasound can confirm this differentiation diagnosis lah. Usually collection of fluid in the intermuscular plane point was shown. Next, cellulitis. So patient presented with swelling, tender, warm to touch, erythematous. Some patient will have fever. So this one we can confirm with our blood test. Next one, phospholytic syndrome, post-thrombotic syndrome is a common complication that can occur after the DVT. So if the leg is diffusely erythematous, more probable is an acute exacerbation of venous insufficiency due to the post-thrombotic syndrome. So the syndrome including swelling of the leg pain, skin discoloration, and skin sore. So this syndrome is caused by the damage to your vein from the blood clot, and it reduces the blood flow into the affected area. So this symptom usually may not occur until a few years of the DVT. So just to share another case that I've seen with Dr. Fairuz before and also Dr. Mashita, there's a Chinese OH uncle. Dia ada cancer and then has recent bedridden for more than 4 days. So came with a SOB and also leg pain. So we carry out with a 2-point compression test, but it was negative in ED, and then we proceed with D-dimer. The D-dimer is more than 20. So that time I consult Dr. Fairuz. So we proceed with treat as PE lah. So patient subsequently medical started with Klaxin while waiting for the CT also. So after that they rule out it's not PE, but they proceed with the Klaxin for a few days or so. At the end, they treated patient as cellulitis. So it's a quite interesting case lah when I was preparing for this PPT also. They straight away proceed with the CTPA first because takut ada PE.
Dia datang SOP. Tapi nampak macam legs tu macam tak swelling sangat. Tapi datang dengan SOP.
Yeah.
So I will just start treat as PE first. Tapi CTPA tu
The main complaint is SOB and so leg pain.
Dia dah cakap dia buat more compression, still negative. So is it still PE? Cakap of course lah. Restrictor tu ada. So patient should proceed with CTPA, tapi while waiting for CTPA start dah. Even if you want to transfer patient from state to suspect, tak lebih. Dia one dose atau one booster kan? Just to highlight dengan orang yang online the discussion that's going on here. I think Yi Wen was telling her story about a case that she encountered recently lah. So it was an elderly gentleman with underlying active malignancy on treatment. So patient presented with chest pain and shortness of breath. And at the time, Yi Wen punya concern yang jadi consult I tu because she did patient shows no signs of DVT. There's no unilateral leg swelling, and then I think Yi Wen performed 2-point compression test of the lower limb. There's no DVT lah. So her concern at the time was should she start treat patient as PE
Sorry,
or
that time the well score was 4.
So well score is high lah because of the active cancer tu. So tapi Yi Wen punya concern because at the time well score was high risk, but patient has no evidence of 2-point compression test was negative in this patient. So her dilemma at the time, should we treat this patient as PE? Because clinically because then subsequently the dimer also was positive. So I think in situation like that, in case like this, you should go with your risk factor, apa probability, high probability, and your clinical punya, your historical punya ni lah, and start treatment for PE rather than wait for the dimer to confirm lah, because wait for CTPA to confirm, because even if CTPA confirm, you tak start lagi, then you're late in starting treatment. But if the CTPA was negative, you can always just stop the treatment lah, and because it's all very short half-life in your treatment. Okay.
So the third part is a treatment. So the aim for treatment is to prevent the clot from getting any bigger, prevent the clot from breaking loose and causing a PE, to reduce the chances of recurrent DVT. So basically treatment can categorize into 3 groups: pharmacological, non-pharmacological, and also surgery. So for pharmacologic is usually only we are using anticoagulant. So these are some anticoagulants that we are using: unfractionated heparin, low molecular weight of heparin, Fondaparinux, and also Warfarin. Non-pharmacologic is used in combination with drug therapy or as monotherapy in those with low risk or contraindication to anticoagulation prophylaxis. It includes early mobilization, foot pump, intermittent pneumatic leg pump, and graduate compression stocking. So this method must be used for more than most of the day for more than 24 hours to be effective. That one.
Okay. The question is, which one is better for the pharmacological treatment of DVT? Either you want to choose the Klaxin or Fonda.
Okay. Fonda, actually we have to look at the our creatinine also. So with the renal impairment, usually we start patient with Klaxin lah.
Tapi for the healthy patient, no underlying medical problem kan. Tentu memang patient ada baseline kan. 1 month, past 1 month just taken the blood and it come out as normal.
Fonda, we'll choose Fonda because low risk of heparin-induced thrombocytopenia. Okay.
But in terms of effectiveness, which one is more effective?
I think it's the same.
It's the same.
I didn't do a research about that.
Okay, kalau based on you punya experience here, which one they choose?
Usually we start patient with Klaxin. A lot of cases I've seen they start with Klaxin. Even in ONG ward also we started with Klaxin as a prophylaxis lah.
Any input daripada online ke apa? Fonda versus Klaxin. Fonda bukan yang dos macam you bagi like ACS kan? ACS you bagi 2.5 kan? But for the DVT you bagi 7.5 kan? Which one is better? Klaxin, Fonda? Saja tanya. Jangan payah jawab. Jangan jawapan. Dan saya go through dia kalau kata based on the prophylaxis, dia the prophylaxis and the treatment dose. So prophylaxis ni macam patient post-op, auto kan, patient post delivery apa semua. Dia ada study, dia kalau nak ada study, the few studies lah. Dia kata compare Fonda dengan Klaxin, Fonda is much better. Dia kata more than 50% prevent the DVT. Okay. Tapi when patient dah ada DVT, DVT tu saya go through dia punya study tu, ada yang support, ada yang tak. So at early part, sebenarnya at early punya management dekat ED macam almost the same lah apa yang I go through sikit-sikit tu lah. Dia Klaxin dengan Fonda. Cuma in term of long term punya management, ada satu study ni kata Fonda is better. Sebab satu dia reduce the risk of bleeding. Reduce the risk to develop HIT. Kan? Heparin induced thrombocytopenia. And then the other thing is dia reduce the recurrence of DVT. Kalau based on yang tu lah. Tapi yang early punya management tu, early management dekat ED level tu, I tak jumpa lah which one is better lah. Maybe kalau ada somebody yang go through the study, maybe boleh share.
I think dalam konteks ED, tak perlu risau sangat. I think dalam kita punya practice, the main difference between Fonda and Klaxin is beza patient tu Muslim ke non-Muslim lah. The controversy of Muslim dengan non-Muslim. In terms of efficacy, there's no definitive study or definitive evidence to say which one is more superior than the other. This discussion also been going on. The other situation yang selalu kita guna Fonda ataupun Klaxin adalah patient ECS kan. So in terms of efficacy, so far the evidence is, you tengoklah mazhab mana kan. Mazhab ni kata Fonda better, mazhab ni kata Klaxin better. Tapi in the end, it boils down to they have the same efficacy. So you're not wrong to start either one. Tapi in terms of, but you need to be aware bila nak start Fonda, patient needs to have a certain EGFR kan. So sometimes you want to wait for the RP. With Klaxin, you have no such concern. So sometimes if you need to start the treatment urgently, might as well start Klaxin. And the other consideration yang bila bercerita pasal Fonda dan Klaxin ni, because patient Muslim dengan non-Muslim lah. Because Klaxin, I think in the early days, because Klaxin, I think in dia punya one of the protein ke apa, it's porcine based. Porcine meaning that daripada babi lah. So Muslim ni kan very sensitive pasal babi ni. So ada zarah babi pun tak boleh dah. So and in the early days of Klaxin, people tutup mata lah because there's no other alternative. So bila datang Fonda ni is plant based. It's not actual heparin, it's a heparinoid. Dia plant based. So then bila dah ada alternative to the porcine based Klexane, then keluarlah fatwa kata now because there's alternative, so Muslim should use Fonda and the non-Muslim can happily use Klexane lah. So and then at the time ada guideline tau dalam perkeliling daripada KKM. Masa tu macam cakap, so you have to ask patient or explain to patient if you really need to start Klexane. You justify lah, cakap, you tell the patient lah, be truthful patient, this got some porcine punya, I don't know, DNA ke or content ke, tapi because you need it, dia kira darurat lah. It's darurat lah bahasa Inggeris apa? Macam darurat as in it's a situation between life and death lah. Meaning that it's allowed. So or macam say dia got CKD ke apa, so pakcik you got these two options tapi this one is not suitable for you because you got CKD. So you have to give Klexane lah. So benda tu become dimaafkan if you need to give babi tu lah. Tapi nowadays I think the fatwa has changed because I think the later generation of Klexane ni has got rid of the porcine punya element lah. So you can use Klexane for Muslim, non-Muslim, safe happily lah. Tapi the issue is bila benda that has been tradition, nak kikis tu susah. And sometimes generation houseman nowadays sometimes don't even know why Klexane, why Fonda, they don't even know the actual reason for the argument between Klexane and Fonda because this cerita ni start from I think 2000, you know, the 2010s, you know, zaman kami semua houseman ni. So your generation tahu Klexane dengan Fonda. Start Fonda dulu. Then kalau RP sana baru start Klexane. Then nobody actually knows the real reason behind it lah. So there's a lot of historical fact lah, historical punya issue pasal benda ni. Okay, I think dah cakap je pasal protamine sulfate tak? Hari tu ada satu patient I think over Warfarin lah. Over heparin kot. Post dialysis. So Dr. Anas cari protamine sulfate, tanya farmasi. Farmasi terkejut. Macam, doktor nak sekarang ke? Tak ada, kami tak ada. So, iyalah. So, so ni lah.
So I'll continue. Unfractionated heparin. So the indication is for prophylaxis and treatment of thromboembolic disorder. So, but this currently only used in specific clinical situations such as severe renal insufficiency, HD patient, pending intubation patient, or clinically ill patient. The prophylactic dose is 5,000 international units. So we have to monitor the APTT when we're using fractional heparin. The target APTT is 60 to 80 second lah.
You pernah guna unfractionated heparin? Pernah start?
Tak pernah.
Pernah tengok start? Kat ward surgical pun tak pakai? They usually like to use this for patient with acute limb ischemia. I'm not sure whether they've changed their preference lah. Zaman I dulu, the only time pakai unfractionated heparin ni surgeon lah pakai. And then kenapa houseman tak suka unfractionated heparin? Every 6 hours kena ambil BWT. Lepas tu 6 hours later baru review. Tapi kalau lah 6 hours later selalu esok lah kan baru review.
So the advantage of unfractionated heparin is the cost, is a DVT prophylaxis of choice in pregnancy. Also, its half-life. So it's useful in patients who want to hour control the intensity of the anticoagulation. The antidote is protamine sulfate, which is Dr. Anas recently shared in our group. So it can completely reverse the action of unfractionated heparin. So with 1,000 international unit equals to 10 mg of protamine sulfate, is able to neutralize around 1,000 unit of heparin. Okay. So the dosage, recommended dosage for initiation of unfractionated heparin, this is a infusion lah. Usually start with IV, 5,000 international unit for non-body weight adjusted, and for body weight adjusted is 80 international unit for per kg. So this is the maintenance dose, and for subcute, this is the bolus and the maintenance dose. So for unfractionated heparin, we have to adjust the dose according to APTT. So this is the adjustment dose we can carry out. So
Jangan terkejut boleh start subcutaneous infusion juga
oh,
this is subcutaneous infusion Jangan ingat subcutaneous varin, this is subcutaneous infusion.
so this is the dosage for unfractionated heparin. Next one is a comparison between the unfractionated heparin and the low molecular weight heparin. So
Ni jadual popular untuk exam saya medical school dulu. Kena hafal. Dia suka keluar masa medical school punya exam. Difference between unfractionated heparin versus low molecular weight heparin. Untuk korang, sebab korang dah tak pakai dah unfractionated heparin, this good to know lah. Nak belagak dengan houseman ke dengan medical student boleh.
So basically, the mode is different. Satu IV, another one is subcut, and then the half-life is different. Side effect is the same for both. The antidote protamine sulfate can fully reverse the unfractionated heparin, but only partially reversible for the low molecular weight heparin. And in renal failure, unfractionated heparin is useful for renal failure patient, but for low molecular weight heparin, we have to use with caution. So avoid using EGFR less than 30 patient. It can increase the risk of bleeding. So unfractionated heparin has high risk of heparin-induced thrombocytopenia compared to the low molecular weight heparin using. So this is the comparison between these two. Next one, Fondaparinux. So usually it's given subcutaneously, and no laboratory monitoring is required as it does not cause any heparin-induced thrombocytopenia. And we have to be careful also when using, because on the renal failure patient lah. So we have to calculate the clinic clearance before we give the patient. Next one, Warfarin. So also it's a treatment for venous thrombosis, PE, and thromboembolic disorder. So not generally used in DVT and PE prophylaxis because of the delay onset of action and higher risk of bleeding. So typical starting dose is 2.5 to 5 mg. Target INR usually 2.5 within the range of 2 to 3. So usually we have to titrate accordingly to hit the INR target lah. And you have to use the bridge therapy, like just now Dr. Virus already mentioned. So because of Warfarin does not, so because the effect of Warfarin is not immediate, it takes around several days to 1 week to deplete the existing vitamin K. So during this time lag, usually we have to protect patient with either Flexin or Fonda before we started with Warfarin, discharge patient with Warfarin. So we have to monitor the INR. 2 consecutive INR value must be seen before we discontinue the low molecular weight heparin or Fonda. This one. No, I took it from the European Society of Vascular Surgery. So next, this is a reversion of Warfarin lah. So basically, for all hospital managing patient of Warfarin should stock a licensed 4-factor PCC, and also usually we're using FFP lah kalau ada bleeding tendency. using warfarin.
Oral anticoagulant yang baru-baru ni, all the Gaban or Gatran semua ni. Why do people like it? Yeah. What's the disadvantage? Wah, apart from kena beli sendiri lah. Dan mahal. Apart from kena beli sendiri dan mahal, what are the major disadvantage compared to warfarin? Dia tak ada. Ni CME specialist ke? CME MO ni rajin pula specialist dia tolong jawab. Sebab dia tak ada, bukanlah tak ada reversal. Until recently baru ada reversing agent lah. But then reversing agent tu it's not easily available and mahal gila lah. Lagi mahal pada ubat tu.